We're moving on now to Christina Federico, who's going to talk about nutrition.
Hello, my name is Christina Federico. I'm a dietitian based at the Manchester Motor Neurone Disease Care Centre, which is situated in the northwest of England. And today I'm going to share some results and findings from a piece of work conducted in response to the COVID-19 pandemic, specifically around the nutritional management of our patients through the use of a multidisciplinary team meeting, which was nutrition focused. And so to acknowledge firstly my team members and colleagues who were heavily involved with this work, so in particular my speech and language therapy and specialist nursing colleagues, other members of our care centre and local services. So a small bit of background, Greater Manchester is defined as a metropolitan county in the northwest of England. And even prior to the COVID pandemic, it was really important with regards to nutritional management of our patients that there was clear communication and good coordination of care. And this is predominantly due to our services being split over different localities. So as a brief overview, we have the Neurosciences Centre where we are based, which is in Salford. The regional long-term ventilation services at a neighbouring hospital. And then dependent on patient need, they would be in contact with various members of community teams, local palliative care teams, and if they required an admission to their local hospital, there would be members at the acute hospitals that would link in and support with nutritional care. As a region, we have had high incident rates of COVID-19, and aside from the national lockdown, we've had periods of extended regional lockdown. I think this piece of work has allowed us to reflect and think back to the spring when a lot of this was unknown and there was uncertainty, and thinking about some of the pressures and challenges connected to the virus and how this has in particular impacted upon nutritional care of our patient group. So early on in the spring, the hospital site where our care centre is based and also where our ventilation service are based, both of those hospitals, their intensive care units became COVID intensive care units and had an increased number of intensive care beds. Due to that pressure and some of the uncertainty at that time, there were changes in the way that services operate. So we had the redeployment of some acute and community staff to support with that pressure, and that included team members that were usually heavily involved in the nutritional care of our motor neuron disease patients. Another pressure was the suspension of elective gastrostomy admissions and the gastrostomy pathway. And this change in a way of working that I think has been incredibly common, but thinking early on when it was a very new thing, the movement from face-to-face clinical review and assessment to virtual consultations and the downside that has, particularly around nutritional assessment. And then we have a vulnerable patient group, and this isn't just specific to nutrition, but it's something that is prevalent that has impacted upon nutritional care. So some of those consequences and challenges are connected to shielding, so social isolation, psychological burden of shielding and how that impacts upon nutritional status. And then we do have areas of quite high deprivation in our region, and issues such as access to adequate nutrition could be an issue. And then more specifically to our patient group, some of the things mentioned, so the suspension of the elective gastrostomy pathway. Early on, there was a lot of anxiety and uncertainty around that, particularly for patients who had a date booked that was cancelled or they were working towards a gastrostomy. And then obviously development of symptoms and the disease advancing. So patients where symptoms progress and it would impact upon their nutritional status, but the backdrop then of the concern about the virus and the changes to local services. And so these concerns led us to set up the nutrition-focused MDT meeting. And I think we felt quite early on that because nutrition was a high area of concern, we wanted to have a forum where we could bring those concerns, have discussions and form appropriate action plans. And that has very much evolved as a piece of work. So we did meet weekly. It then was reduced to fortnightly, and it is currently monthly. And we have adopted a traffic light system, so red, amber, green, and the green now lower risk patients. Some are just kept on the list, almost like as a surveillance and monitoring system. And so in terms of how the MDT would operate, in terms of identifying patients to be listed for discussion, that was predominantly led on by the specialist nurses. And action plans were always formed for the patients, and that could really vary dependent on patient needs and wouldn't be different, I think, to usual care in terms of bringing forward clinical reviews as needed and linking in with community teams. But perhaps because of the different ways of working and changes in services, there was a heavy emphasis on liaison between the care centre and local teams, so constantly referring back and checking where things were up to. And then a key component of the MDT forum has been around coordination of care with regards to tube feeding. And so for patients that weren't able to access the gastrostomy when those services were on hold, we were able to facilitate discussions around accessing shorter term tube feeding options such as nasogastric tube feeding. But I think upon reflection, the MDT forum allowed us to emphasise the concerns around the absence of the elective gastrostomy pathway, and it enabled us to progress forward and to develop a COVID-specific pathway that I know many centres now have. And also with our new way of working and using technology, we could link that in. So, for example, we are able to offer like a pre-gastrostomy admission contact with the patient, and we can do that over the video consult. In terms of data, we were keen to look at outcomes, both to assess the impact that COVID has had with regards to nutritional care, but also with this being a new piece of work, and to look at the nutrition outcomes. And at the time of submitting the abstract in August, we had 36 patients who had been discussed at the Nutrition MDT, but as is very common with our patient group, it was a very quick change in clinical picture for many patients. And we also have had a significant number of patients that have been added for discussion in the last few months. And so at the time of presenting in November, the updated data is that we have 57 patients who have been discussed at the Nutrition MDT, and for some of those patients on multiple occasions. Just to break down in a little bit more detail, 68% of those patients have bulbar symptoms, and just over half have respiratory involvement. We have a small number, so 12%, where there was absence of bulbar symptoms, but the respiratory issues were causing nutritional difficulties. And then another useful piece of data is that we had 11% of patients who had been diagnosed prior to the pandemic, but then presented with bulbar symptoms during the period of the pandemic, and that was a trigger that meant those patients were listed for discussion at the MDT. 42% of our patients were newly diagnosed during the pandemic, and of those new patients, so 24 in total, 75% had bulbar symptoms and a third had respiratory symptoms. A key role of the MDT was to form appropriate action plans and to link in with community services for ongoing support. And it was of interest that we had a higher number of patients that were under the care of local speech therapists compared to dietitians. But through discussion at the MDT, we were then able to facilitate referral for 44% of patients onwards to local dietetic services. In terms of nutritional risk, we obtained data about weight changes for the patients who were discussed in the MDT. And looking at percentage weight loss ranging from no loss to greater than 10%. This was weight changes that occurred from time of diagnosis to time of discussion at the MDT, and that ranged from 1 to 18 months. And so perhaps unsurprisingly, because it is a group of nutritionally compromised patients, we had 33% that had experienced greater than 10% weight loss. And then a point that's perhaps specific to this current way of working, and one of the negatives of the remote working, we have 19% of patients where we don't have accurate data around their weight changes. So we had some subjective feedback from patients about weight loss, but we didn't have definitive measurements to say the exact percentage weight change. As mentioned, the MDT forum was incredibly useful in facilitating discussions around tube feeding, and so looking specifically at gastrostomy outcomes with the gastrostomy services all now fully resumed. There were 47 patients in total where gastrostomy was indicated. It's quite a diverse picture in terms of outcomes and perhaps a reflection of the quick changing clinical picture that can occur with our patients. So 34% now have a gastrostomy placed and 17% are working towards, so in the process of having booked or have a date booked. 21% declined. And then the last two categories in terms of not suitable and missed is perhaps where there is some overlap. So those that were considered unsuitable had a fast deterioration in their disease, and so gastrostomy was perhaps identified early on, but then as things progressed, it was felt that it wasn't suitable due to advanced disease, or with some of our frontal temporal lobe dementia patients, through the best interest process was felt not to be within their best interests. In terms of those that were considered to have missed, this is where COVID perhaps does have an impact, because we had a small number of patients who had been booked in for a gastrostomy prior to lockdown and changes in services. And for 3 of those patients, we considered nasogastric tube feeding either as a short-term or longer-term option if gastrostomy wasn't then available. They all declined that option. And then we did have a small number of patients, so 2 patients where gastrostomy had been discussed and worked towards prior to their MND diagnosis because of bulbar symptoms. They were then actually diagnosed, had a confirmed diagnosis of MND during inpatient admissions, and at that point had advanced disease. And so perhaps some overlap between the missed and unsuitable categories. Then looking at gastrostomy outcomes for our higher nutritional risk groups, so those that experience greater than 10% weight loss. Again, it varies, so some have now had PEGs placed, so 26% and 16% working towards, but then 26% considered not suitable. And again, with the missed category, they're patients that have had quite advanced disease or have frontal temporal lobe dementia, and some overlap again, and then 16% have declined. Because the nutrition-focused MDT has always been available since the spring, so always there for the newly diagnosed patients since the pandemic, thought it would be useful to look at the data for the patients that have been diagnosed during the pandemic to see about gastrostomy outcomes. And so for this group, 40% have now had a PEG placed and 20% are working towards. And as per the previous slides, we've got the mix of the declined and for the not suitable and missed, the patients that are in advanced stages of the disease. I think anecdotally for me, I feel there perhaps have been prompt actions around gastrostomy decisions, and I think some of that is due to the MDT forum, but also I think from patient consultation and feedback that COVID in itself has perhaps contributed to this, because patients have taken on board the advice around window of opportunity for gastrostomy and factored COVID into that. So I think there's a keenness to have gastrostomy done as soon as possible when fit and healthy, considering the virus as an additional risk and the uncertainty around kind of future hospital admissions and COVID being a risk factor. And then the final piece of data is around inpatient admissions. So as mentioned at the start, another component to nutritional care and teams that are involved in nutritional management of our patients is around inpatient admissions when patients perhaps go to their local hospitals. And so I thought it would be useful to look at the inpatient admissions that occurred for our patient group who were discussed in this MDT. And so in total, we had 28 admissions, and half of those were elective for the gastrostomy insertions once those services resumed. I think an interesting point for us were patients that were admitted as an emergency and were placed nil by mouth, so 3 in total. And this was a very common theme for reasons for patients to be discussed at our MDT to kind of provide that in reach to the local hospital teams. And for those patients that were admitted and placed nil by mouth, they were people where there had been previous discussions about gastrostomy not being a suitable option, or they did not wish to have a gastrostomy. But then we're in a situation where they were nil by mouth, and so through the work that we did as an MDT and linking in with the local teams, the decision was made for all 3 of those patients to risk feed orally. And so in terms of recommendations, I know that having nutrition-focused MDTs isn't a new thing, but I think doing this piece of work for us as a care centre has strengthened the argument for having that as part of our standard care as a centre. It also has highlighted to us the importance of having good communication and coordination around gastrostomy, and in particular having pre-gastrostomy admission clinics, and also planning clinics when people are still in the decision-making process. And I think for both of those points about the future use of a nutrition MDT and a gastrostomy specific service, the new way of working and using virtual consultations has opened up, I think, opportunities to manage both of those services. And so rather than it just being done by the care centre staff, we can engage and link in with our local services. And also from a patient experience perspective, I think rather than having the same discussion with different members of different teams, it can help to bring that together, and so would be better for the patient. And then I think finally, in relation to the point made about the inpatient admissions where patients were placed nil by mouth, but there had been previous discussions in detail about tube feeding, and this wasn't something that was for them. Unfortunately, we do still have patients that don't make advanced directives with regards to artificial feeding. And so perhaps again, with our new ways of working and virtual platforms and information sharing, there perhaps is a recommendation to look at how we enhance care to ensure that that information is clear and can be shared across the different teams. And so I think overall with all of the recommendations, the virtual way of working presents us with opportunities to look at improving patient care. And so thank you, and I'm happy to take any questions.
Thank you so much. We do have some questions. In your opinion, can a PEG be inserted too early and possibly lead to increased risk, or is it better to have it earlier?
Well, it's very individual, but I think prevention really is the key in terms of minimising the risk. So I do think with the evidence that's coming out about weight loss as an indicator, I think early placement is better, but it's having that detailed discussion about the care of the tube with the patient.
Yes. I mean, I think we always have to think individually with each person. And you made some very good points about how electronic and virtual now is really improving care as well. And I assume that moving forward with, even with COVID, maybe slowing down, you'll still continue to do that.
Definitely, yeah. And I think, obviously, I know that some colleagues from our care centre have presented previously about our clinics. And I think for our patient group, it's obviously really useful to have some face-to-face contact, but those sort of in-between contacts, so particularly when we're leading up to gastrostomy admission and planning, I found it being quite easy to have that video consultation with patient and their relatives, and we can kind of further plan for the admission. So I think definitely a combination would be the way forward.
Yes, yeah, that sounds great. You guys are doing great work, and I'm going to let you again go to continue the chat in the chat box if anyone has any further questions for Christina. And we're going to move on to the next presentation. Thank you.
Thank you.